Good evening, doctors. First of all, it's our pleasure welcoming you all. Greetings from Boringa. And it's our immense pleasure to welcome our first speaker, Professor Dr. A. Ramachandran. And you all know very well, Professor Dr. A. Ramachandran have contributed extensively for diabetes care and epidemiological research in India for more than 3 decades. His vast experience and peerless performance have bestowed on his national and international recognition and awards, besides responsibilities in the international association and organization. In fact, he has numerous publications on diabetes in different journals. So, welcome, doctor. So, the first topic is evolving evidence with DPP4 inhibitor, implication on clinical decision making. Over to you, sir.
Thank you. So the next 20 minutes I'll try to talk something about evolving evidence with DPP4 inhibitors, implications on clinical decision making. Thank you, BI, for inviting me for this symposium. I hope some more people will come in. These are my disclosures. And of course, there are numerous challenges when you start treating diabetes for achieving optimal glucose control. And as you can see, this depends upon the age, HbA1c level at the start when you see the patients, weight, hypoglycemia, and of course comorbidities such as the renal function and other comorbidities. Of course, tolerability of drugs. We always have to consider the cost, sustainability, and compliance. It's not enough that you write medicines, but a patient has to be compliant with that. Treatment selection also, from the doctor's point of view, is complicated by many number of factors because there are many different types of patients. Every day we see patients. I don't think any two patients are similar or identical to each other. And then, as we have already said, weight and comorbidity, and the risk of hypoglycemia also differ from patient to patient. Even not only susceptibility to hypoglycemia, also the way they perceive hypoglycemia is also different. Polypharmacy and adherence and need for dose adjustments. Polypharmacy is very important, especially for those patients who are coming to tertiary care where patients have already had diabetes for many years. And there's going to be an old saying that if the patient is already on 20 different drugs and he has got 10 complaints, you stop all the 20 medicines, and 2 days out of the 10 complaints, you will have only 2 complaints. So therefore, you should know that polypharmacy is also an important issue, and sometimes trimming the drugs can be one of the major things that can help the patient. Of course, there is a need for glucose lowering medications which simplify the management. We are always confused which one. Even after many years of treatment and experience, we don't know which drug will be the right one for the patient who is sitting in front of you. We need good glycemic control. That should be weight neutral. Of course, low level of hypoglycemia. If we can just close your eyes and give one drug which does not need much of dose adjustment, then that will be pretty good because you don't have to worry about somebody waking you up in the midnight. Then, of course, you need renal safety and cardiovascular safety. So that should be an ideal drug which you want to give for type 2 diabetes. In this, the DPP4 inhibitors are simple treatment options, as you now just discussed, because sustained efficacy across a broad range of settings in patients. It's easy to use because titration is not necessary because it did not produce hypoglycemia, pretty weight neutral, and hypoglycemia, of course, is rare because they do not produce low blood glucose. So what do we know already about DPP4 inhibitors? We know that comparable efficiency of all DPP4 inhibitors is pretty comparable. Meta-analysis of large number of RCTs comparing the efficacy have shown that it's linagliptin, nalogliptin, Saxa, Sita, and Vilda almost ranges from 0.67 to 0.74 HbA1c reduction. But also it depends upon where the baseline HbA1c. If the baseline HbA1c is pretty high, you may have much better glycemic response. So therefore, that is important. But this is the weighted mean HbA1c change percentage reduction that you see, HbA1c reduction from a large number of randomized controlled trials. Also have some evidence to show, whether you believe it or not, that there's probably little better efficiency in HbA1c reduction in the Asian population. Of the Asian population here, almost 60% of them are actually Indian patients. We have seen that there is a difference in the beta cell secretory capacity at diagnosis between the Asian patients and the white patients. One of the reasons could be that our diagnosis is pretty late compared to, because the average HbA1c at diagnosis in the Asian or Indian patients is much higher, almost 1 to 1.5% higher than if you want to compare with those patients from the West. But we don't have to say that the patient who is in the United States is the standard patient. Maybe he's not the standard patient. Our patient is a standard patient. So why not we say, because we are a larger number of people with diabetes compared to those countries. So whatever it is that if the beta cell deficiency is more, then probably insulin secretagogue has a better role to play in controlling diabetes, and therefore it may not be surprising that you may give better HbA1c reduction in patients in this part of the world who have a lower beta cell secretory capacity. The other point about DPP-4 inhibitors are they're weight neutral. On the top you have DPP-4 inhibitors compared with placebo, and you can see that all the dots are on the unity, and on the lower part you have the comparison between DPP-4 inhibitor and glipizide, which is the sulfonylurea, and as you can see, once you use sulfonylurea, actually there's an increase. So compared to sulfonylurea, definitely DPP-4 inhibitors are more weight friendly, you can say, and you can say weight neutral with placebo. Okay, this is about hypoglycemia. I'm sure all of you who have used DPP-4 inhibitor are quite convinced that it does not produce hypoglycemia. Whenever you have see patients who are already on sulfonylurea and metformin, and you add a DPP-4 inhibitor as a third drug, if the patient is experiencing hypoglycemia, it is not because of the DPP-4 inhibitor. Patient will come and tell you, I started this tablet and I had hypoglycemia, so I think this is too powerful. He won't realize that it is because of the sulfonylurea. DPP-4 inhibitor brings it down, and on top of that, the sulfonylurea produces hypoglycemia. So what you can see here is that DPP-4 inhibitors are quite safe and do not produce hypoglycemia, because the mechanism of action is very well known. Its action is dependent on the blood glucose levels. When the blood glucose goes down, it actually stops working, and actually glucagon comes out. Got a double threshold action. Now the next question is, are all DPP-4 inhibitors the same? Actually, they're all same efficacy, weight neutral, and no hypoglycemia, and well tolerated. So on the left hand side, you have all the similarities of the DPP-4 inhibitors available today with you. On the right hand side, there are differences in the PK/PD differences. To some extent, cardiovascular safety probably and the saxagliptin story, and kidney safety. So we're going to tell which are the now. Linagliptin seems to be a little more safer as far as kidney is concerned. With its unique mode of elimination, linagliptin is the only available DPP-4 inhibitor that does not require dose adjustment for any stage of renal impairment. As a whole, incretin-based therapy, whether it is GLP-1 analogs or DPP-4 inhibitors, are pretty safe actually in diabetic kidney disease. I think that's a general statement. You can use GLP-1 analogs too. But of all that, linagliptin seems to be much more safer, because the proportional lean excretion is much less with linagliptin compared to sita, vilda, sux, and elagliptin. So it does not require dose adjustment at all, and those other DPP-4 inhibitors, theoretically speaking, need dose adjustment because they can get accumulated even though they do not produce hypoglycemia. So therefore, that's important. But generally, you should know that incretin-based therapy, which is, just want to repeat that point, whether it is GLP-1 analogs or DPP-4 inhibitors, are pretty safe in diabetic kidney disease. Linagliptin demonstrated safety and efficacy evidence across the spectrum of chronic renal disease. HbA1c reductions with linagliptin is quite robust in mild renal impairment, moderate, severe ESRD, and new onset diabetes after transplant. You can use it. Today I had a lady who actually came out of dialysis because she had acute renal failure, and she's on insulin, and the only oral drug which I could prescribe her was actually linagliptin Trendo. So, and there is a very good response to that. We could reduce the insulin dose because she is on multiple doses of insulin regimen. So, at any stage of renal failure, still there is good efficacy for linagliptin. Okay, now coming on to cardiovascular safety, maybe I think renal impairment is probably more practical, more important from a daily practice point of view. But then we also got cardiovascular and kidney safety from the long-term perspective. If somebody is sitting in front of you, and of course, many a time I also say a common physician, a general physician or one of us, we may not be that worried about somebody getting a heart attack 20 years later or 10 years later, but we want to give drugs which are safer for our patients because they live long and continue consulting you and paying your fees regularly without dying early. Okay, here we are talking about the studies, 4 studies with DPP-4 inhibitors, Sabertimi with saxagliptin, Examine study with alogliptin, TCOS with sitagliptin and Carmel. All are pretty big studies, 16,000, 5,000, 14,000 and 6,000. What is shown here is that in most of the randomized control trials, when you have a primary or endpoint, which is usually the 3-phase or the 4-phase, the secondary endpoints also include the primary outcome. That is statistically. But in case of Carmelina, it is nice to say that composite kidney endpoints were also a predetermined secondary endpoint. When you predetermine, then you have definitely better statistical power to decide. This shows you the comparison of the baseline characteristics showing that you may remember that we're coming into the Savior trial with saxagliptin, there was an increased incidence of heart failure, and so therefore now you have the black box even now on saxagliptin, whether it can be generalized. Unfortunately, it got generalized by the FDA. So in this one, the Carmelina, which actually compared linagliptin with placebo, you had a pretty good number of people, but 27% of people with prior heart failure and cardiovascular disease in 57%. So you had larger proportion of patients with heart failure. So that is pretty good to test whether there is an increased risk of heart failure with linagliptin compared to the placebo. Because we want to be very sure about it. We know that saxagliptin increases the risk of heart failure. And what you see here is, this is the cardiovascular MACE outcome, that is cardiovascular events, pretty neutral. As you know, DPP-4 inhibitor cardiovascular safe. They do not have, they are non-inferior. They do not have benefits from cardiovascular point of view, but they are cardiovascular safe. As far as this is the hospitalization for heart failure, as you see in the top, Sabertimi, saxagliptin unfortunately increased heart failure episodes significantly, and that was the big point which actually made people to think about, are DPP-4 really safe in patient type 2 diabetes who have increased risk of heart failure. But that was not reproduced in any of the other DPP-1 inhibitors like alogliptin, sitagliptin or in linagliptin. And actually sitagliptin is a much higher number, 16,000 patients. That is one of the largest. And Carmelina actually produced a little better results. As you can see, it is 0.9, so it is a 10% reduction. So you can say linagliptin is pretty safe from the heart failure point of view. Of course, very recently you have the Carolina study, which is actually comparison between linagliptin and glimepiride for cardiovascular outcome, and that came out as neutral, which is very good. That is good actually because that is a jackpot for glimepiride. We have been using glimepiride, and we all were a little worried whether are you really good in using that because sulfonylurea has been dumped except for glycoside and glimepiride. The glipizide, any other drugs you are using can increase cardiovascular events or risk of cardiovascular. But we know now from this study that glimepiride at least is head-on comparison with DPP-4 inhibitor has shown the safety. So actually Carolina is putting the stamp on glimepiride rather than on linagliptin. But you can say that linagliptin is safe compared to sulfonylurea, and both are not. But more importantly, what is the benefit of using linagliptin over a sulfonylurea like glimepiride. Although both did not show any difference in cardiovascular outcome, there is a difference in hypoglycemia, as you can see. What you see on the left extreme is any hypoglycemia. Look at the difference, 10% with linagliptin, almost 38% with glimepiride. So that reduces your quality of life. And moderate to severe, almost 31 and 6.5. So there is a very wide difference in the incidence of hypoglycemia. Well, one of the important points you must decide, it's important to understand what is the importance of hypoglycemia. First, of course, quality of life, very important, and weakness, etc. Secondly, suppose you continue the trial for more number of years, whether this increased incidence of hypoglycemia would have actually ended up having more cardiovascular events is a big question, because you know that hypoglycemia, whatever be the mechanism, is an important driver of increased risk of cardiovascular events. So therefore, you can say that definitely linagliptin is much safer compared to glimepiride from the cardiovascular study. And of course, you know that sulfonylurea can increase your weight. Even though it is not increased, you can see there is a very beneficial weight change with linagliptin, and the difference was pretty impressive. So DPP4, this has actually again convinced us that linagliptin is not only weight neutral, but compared to sulfonylurea reduces. So finally, no increased risk of heart failure was consistent across high groups, and it showed that regardless of the baseline characteristics of the type 2 patients sitting in front of you, whether he had a history of heart failure, he had renal impairment, already established cardiovascular disease, also with insulin, and any part of the world or any ethnic, and of course even elderly people. Now, as far as the kidney is concerned, in Xavier and TCOS, these were actually exploratory analysis because they were not predetermined endpoints to look at kidney. Even in, of course, they have shown benefits, and the post-hoc analysis have shown in Xavier with saxagliptin, doubling of serum creatinine and all that. And then TCOS also showed post-hoc renal analysis of albuminuria. But in Carmelina, there is pre-specified renal endpoints specifically showing that it has got renal benefits, and what is shown was that there is a significant reduction in albuminuria progression, and also ESKD, that is, and renal death was less, even though not significant. So there is some, definitely there is important issue to talk about, that it actually has got benefits from the renal point of view. So to sum it up, linagliptin has the broadest clinical evidence of efficacy and safety. Among the DPP4 inhibitors, the one DPP4 inhibitor you can close your eyes and give to the patient in front of you is linagliptin. You don't have to worry about dose adjustment, hypoglycemia, weight gain, nothing. So just give it and let the patient go. He will not come back to you with any complaint of any of the safety points or any hypoglycemia or side effects. So linagliptin is appropriate, and one good thing is only single dose, one dose once a day. So adherence will be better always, irrespective of the kidney function, liver function, cardiovascular risk, age, body mass index, background diabetic type 2 therapy, and disease duration. Thank you.